from joining us today. We've got Dr. Weltman joining us again from Sydney, which is fabulous. Thank you so much for taking the time. I know that you're making time out of clinic to come and join us today, so we won't keep you too late, but thank you very much for taking the time. We do really appreciate it.
That's okay.
Just a wee bit of housekeeping before we start. So please remember that these Q&As are not taking the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. So we will likely generalise your question a bit to support that. But if you need any specific help with a more detailed issue, please reach out to us on the helpline. As I mentioned, I'll be recording the session here within ClickMeeting, which will be uploaded to our YouTube channel. But just for awareness, the right-hand side of the screen where the questions can be entered there, that part of the room isn't recorded. It's just the two video streams that are recorded. So that's a safe space to ask any questions. So I'll get started on the questions that we've had sent in, but if you've got any questions for us, please just pop them in the chat here and I'll keep an eye for them as well. Right, so I've got first question up this morning. We've got a lot of good questions again this morning. First question up this morning is, I'm suffering from recurrent cellulitis in my left lower leg. Could this be connected to PBC?
Okay, no, thanks for the question. It's almost certainly not going to be PBC related. Cellulitis is quite a common medical condition, and this is, for those who don't know, it's infection of the skin and the tissues just under the skin, most often in the leg, but it can be anywhere in the body. And it's usually a bacterial infection requiring antibiotics, and it has nothing to do with PBC. Because you've got patients with PBC can get anything else that anyone else can get, as well as on top of the conditions that are associated with PBC.
Right, thank you. A similar question, is acid reflux connected to PBC or potentially a side effect of URSO?
So acid reflux is a very, very common medical condition, and it has no connection to PBC. It is definitely not a side effect of URSO or any other PBC medications.
Great, thank you. Right rib pain comes and goes. Could it be related to PBC? If so, how can I alleviate the pain?
It's almost certainly not PBC related, and probably should be looked at as a separate issue, to be quite frank. Yeah.
Great, thank you. I'm sure this came up before as well. Are recurrent UTIs common with PBC?
Probably not. It's common. So most individuals who have PBC are women above 50. Most of the people, not everyone, but that's the bulk of individuals. And UTIs are more common in women of that age anyway. Mm-hmm. So it's hard to really be totally dogmatic, but probably most UTIs are not related.
Is brain fog indicative of advanced PBC, or can it be prevalent?
Oh, you've disappeared sound-wise. You've frozen.
Oh, have I? Can you hear me?
Yeah.
You
got into the brain fog, and then is it indicative of advanced PBC?
Or can it be prevalent at any stage?
That's a very important question. Brain fog / fatigue, this all overlaps. And I'm going to assume, brain fog can be for lots of reasons, not just PBC. So someone with PBC can have brain fog and or fatigue that may be entirely PBC related, but it may be independent of PBC for some other reason, because it's a reasonably common thing. But in saying that, let's assume it's PBC related. You can actually have, it's not necessary, people who have more advanced disease are going to get more fatigued, but you can have very mild disease and you can have a lot of fatigue and brain fog with very minor disease and well-treated disease even. Mm-hmm. And so it doesn't always parallel the severity of liver disease. And I think that would answer your question.
Yeah, definitely. And I think we hear that a lot, is that the blood test results don't correlate to how your symptoms can be. You can be experiencing severe symptoms, but as you said, your disease is under control. Next question's around patients, the younger patients. So What are the extra risks or symptoms young diagnosed patients, so younger than 35, need to take into account?
Okay, so then, on a day-to-day basis, it's no different to anyone else of any age. The thing is, you've got the disease if you're young for much longer. So it's much more likely to be progressive. Young people also who are associated with younger people tend to, the data shows that young people tend to just have more aggressive disease by and large. And that's not every young person who has PBC. So we shouldn't say every young people, but if we take a group of people, say in their 30s and a group in their 50s, many more in the 30s will have more aggressive disease through the cycle of PBC than those in their 50s. And by aggressive disease, I mean more liver damage, more liver inflammation, more fibrosis and scar tissue, and much more likely to have consequences. And if I see a younger person in my clinic, in the back of my minds, if they don't respond to first line therapy, we always keeping a closer eye and very vigilant about escalating their treatment now that we have second line therapies, and just keeping not all of them are going to run a aggressive course, but just making sure that that individual's not. And sometimes we see those individuals, this is personal experience, that's a bit anecdotal, we see those individuals just running quite smoothly, responding well to treatment, have a pregnancy, and it all falls apart afterwards. The disease escalates. And there's just not a lot of those individuals, so there's not a lot of data on that, but that's been some of our experiences.
Thank you. There's just a question in the chat here, just based on our previous question about brain fog. So I think it's in relation to the brain fog question. Could it be because of excess calcium in the blood?
It could be. There's lots of reasons for brain fog, but the excess calcium is not the PBC's doing. But for example, there's a disease called hyperparathyroidism, and you have excess calcium, and it's got nothing to do with this illness, but those people have brain fog.
Okay, thank you. We have a patient with PBC who's going to be starting chemotherapy for endometrial cancer, and she's just asking, is there anything that she should be taking into consideration because she has PBC before she starts that?
Okay, well, that's a tough situation, and not a situation that's again well studied. But if I was seeing someone like that in my clinic who's starting chemotherapy for whatever cancer, I would want their PBC to be well controlled, ideally before they start their chemotherapy. But there's probably, if it's well controlled, there's probably no special precautions. If someone has very aggressive liver disease, be it PBC, be it anything else, actually, it's going to pose some challenges for the oncology team, and we would keep a much closer eye on that individual. But if someone's going into chemotherapy with well-controlled PBC, there's no special precautions, and probably no impact unless there's a few chemotherapeutic agents that are liver toxic, but not that many these days.
Thank you. Next question is, can osteoarthritis cause an increase in ALP?
I'm getting asked this a lot lately. Definitely not.
No. Interesting, we're getting asked a lot, isn't it? But it's not actually
true. I gave a talk to gastroenterologists recently, and I was shocked that they believe it's a cause for a high ALP, and it's definitely not the cause. There's only, in adults, there's only one specific bone disease that's reasonably, it's not even common. Paget's disease causes a high ALP. Some tumors in the bone can cause a high ALP, but really, by and large, bone disease is bone disease. It doesn't cause a high, most of them don't cause a high ALP, and joint and osteoarthritis is a joint disease. It definitely doesn't cause a high ALP.
Thank you. So when URSO is declared to be working, does that mean blood work returns to the normal range or close to normal, but not always perfect range?
So our goal would be to normalize the ALP, and that's with whatever treatment, but that's with URSO. But if it's close to normal, it may be acceptable, and you may not need to escalate treatment. It depends on a whole lot of other health issues that may be comorbid or other medications that that individual's taking. So it's hard to individualize it, but the target should, in the ideal world, the target should be to normalize the ALP, and that's the view of a lot of experts now, and I think that wasn't the view several years back. Several years back is just get the ALP down, but it may be acceptable to get it close to normal and not need a second line agent. It may be acceptable. Everyone's got different individual circumstances, and we accept that sometimes someone's got a slightly elevated ALP, and we either don't have access to escalating the medications because of the rules in Australia or the regulations around that, or it's just reasonable for that individual not to overburden them with too many medications. But the goal when we start treatment, and I tell patients this, in the ideal world, the goal would be to normalize the ALP. We may not get to that goal, but that's our aspiration.
And that is certainly something we're seeing the community back and want that to happen, that we're now striving for normal. Can PBC cause trouble sleeping? And is there something that can help with that?
So I don't think it directly causes trouble sleeping. The issue is our patients are bothered by a whole lot of other things. They have fatigue, so sometimes they nap during the day, and that changes sleep rhythms, and it's not ideal. So then they can't sleep properly at night. They may have a lot of itch, which keeps them up. They may have, some people get very stressed around the diagnosis and their health, and that may disturb sleep. And they may have a whole lot of other sleep disturbances that are not PBC related, like we all get. And there's really no specific treatment other than the usual things where we should have good care, try and get some exercise, try and eat correctly, and try and have some good sleep hygiene where you can. But there are things that help sleep, and whether they're appropriate for you as an individual or not, I think you've got to discuss that with the doctor, your doctor, to see whether they're appropriate or not.
Great, thank you. Our next question's around hay fever medication. So we have someone who's been taking URSO for about 6 years and OCA for just over a year, which has brought their ALP nearer to normal level, as it's usually around 200. Question is about our much needed hay fever medication. Having used a Beconase inhaler successfully for years, it's now drying up our nose excessively and painfully and seems to increase dry eye irritation, so stopped using it. Can't use, apologies for my pronunciation, I can't use ceritracine as it dramatically increases my fatigue symptoms. Loratadine doesn't suit. Can I take fexofenadine permanently without any further damage to the liver? There seems to be a lot of complex patient information attached to it, and just a bit concerned about that.
Yeah, I would think, I'm going to talk in general terms because I don't obviously know you as an individual, and you should ask your doctor those questions because they know you and your health. I would think on basic principles that's reasonable to do, to take that, and they'll be able to monitor your liver and see if that's safe and okay for most individuals. That's how I would think about it. Yes. With the dry eyes and all of that, just discuss with your doctor if they've looked for what Sjogren's syndrome. Sjogren's syndrome is an autoimmune condition that mainly affects salivary glands and lacrimal ducts, which hydrate our eyes, and you should make sure you don't have that. there are blood tests to assist in the diagnosis of that condition. And your doctor may have already assessed that, but we don't test everyone. We just test people who are symptomatic.
Great, thank you. Do people have issues with their hands and skin becoming sore on their fingertips? I've developed a red, blotchy skin on my hands, and I don't know if it's due to the toxins build up in my body or some other issue. Any information would be good.
Interesting question. No, I don't think that's related to your PBC. We have lots of things with PBC, but we're not going to blame that on PBC. And there are other autoimmune conditions that can present in that way. So it's worth having a chat to your doctor about that. But it may be a skin condition or something entirely unrelated. And I suspect that's more, talking in general terms, it's much more likely.
Yeah. At a recent visit to my dentist, I was told that I have significant tooth decay caused by excess acid. I do not have any symptoms of reflux and want to ask if there is evidence that PBC or urso would have any effect on the production of acid. I have had an endoscopy and there was no problem identified, diagnosed with PBC 21 years ago.
So, so that's a long history of PBC, but PBC does not affect acid reflux, dentition, and neither do any of the medications we use, including urso.
Okay. Can a patient have PBC and PSC?
Very, very, very rare form of what we call overlap if we have more than one autoimmune liver disease. The most common overlap is autoimmune hepatitis and PBC, but there are patients who have described as having PBC slash PSC, or even PBC slash PSC slash autoimmune hepatitis. Very difficult diagnosis because there's no, other than a very characteristic imaging or liver biopsy of PSC. It's very difficult to differentiate from PBC, but yes, very rarely you can have both. We've been looking at a patient very recently who may have both, and the doctor brought the patient to the meeting. Didn't, it's a very rare event, didn't even put that in as a consideration, And we're not blaming the doctor. They just didn't think that was a possibility, but they brought it to the meeting for review,
Yeah. If someone tests positive for an AMA test, but ALP and AST are normal, what would be done? Would it be a watch and wait situation?
Generally, yes. That's the current philosophy. Prevailing philosophy is that person's predisposed to having PBC. I'm not sure why an AMA was done if someone had normal liver tests, but we come across those sent to us from time to time, and generally it would be a watch and wait. Yeah.
Thank you. Patient recently diagnosed with PBC, not started urso yet. Any tips?
Okay. Start urso. That's the first tip. And I think that this could be a lot of tips. I think a new patient, everyone's different. I think people should be encouraged to be informed about their disease and any chronic disease. So whether it's PBC or Crohn's disease or emphysema, you should be informed about your disease, and I guess that's what you're doing at the moment. You're informing yourself.
Found us to ask a question, so yeah, I like that.
So information is good. I think it's one of these diseases because it's a very intangible disease and not visible, and it's rare. No one's heard of it. If they're close friends or family members, it's useful. I like to give patients a bit of literature to say, take that, let your family read it, let your kids read it, or whoever, husband, wife, whoever, if they want to read it about your disease, because if they do, they have a much better understanding of the reality of this condition, because a lot of these symptoms and issues are quite intangible to to someone who's not going through it. So that's the second thing I would do. And the third thing I would do is I would take control, engage your specialist and your general practitioner, and I would be very positive that you've come into this disease in a fortuitous time where there's expanding treatments for a rare disease. There's a lot of rare diseases that have absolutely zip, and if we think not even half a generation ago, we didn't even have URSA.
Yeah.
So be positive, look after yourself, take this as an opportunity to reevaluate your general health and well-being, and empower yourself by learning, and engage the medical profession in a positive way, and that you're going to be the best patient and that you want the best treatment.
I love all of that, and we're
That's right,
absolutely here
Mo?
to support. Yeah, I love that, and we're here to support on all aspects of that as well. On our website, there are our resources in terms of information for sharing with friends and family. There's also some literature and some videos we've specifically done for children as well. If you're needing some help to share that with younger members of the family as well. And we're always here on the helpline if anyone wants to chat as well. But yeah, I love the be informed and take control. And the fact that there's a question in here, so be of us ready to come to you is brilliant as well. So if bloods are doing okay on a lower dose of URSO, should the dosage automatically be increased to what the chart says for the weight, or is a lower dose acceptable in this situation?
Well, that's a hard one, because there's really a lot of literature now saying we should optimize dose, and Mo has been to a lot of our medical meetings where it's discussed that a lot of patients are undertreated. But I guess if your liver tests are perfectly fine, and in particular your ALP is fine, then it's a bell-shaped curve. You're going to be the outlier, and it's probably okay, to be quite honest.
We've touched on this a wee bit earlier actually, but it's just asking a bit more about Sjogren's and what treatment options are available. You mentioned earlier that it can be, is it diagnosed via a blood test?
There's a blood test, and then there's some old-fashioned tests they do to measure how much liquid there is in the eyes. There's a thing called a Schirmer's test, which they don't often do. The blood test is pretty good with the clinical picture. There's no great treatment really. There are some in some cases doctors use immunosuppressive medications, but it's mostly liquefying the mouth, liquefying the eyes with the specific eye drops that mimic tears, and there's no specific treatment other than using those to supplement your day as you go along with your day.
Okay, thank you. Patient asking about side effect of URSO. They're saying it brings them out in a rash. Is this common?
Okay, I've never come across that. It's not impossible that people have side effects of the drug, and someone gets a rash with a drug. That can happen with any medication. In all my decades of treating this, I haven't come across that. Doesn't mean it's not real. So if you can't tolerate the drug, you have to be escalated to a second line agent. And I'm not sure where that individual is who's asking the question, which country, but every country has different regulations around these second line drugs. So I don't want to speak on behalf of you and what you should do. But if I had someone in my clinic, we'd say we could get, at the moment, we can get them we could get them access to obeticholic acid. So we would switch them to that.
That actually takes us perfectly on to the next question, which is, URSO is not working for me. What's the alternatives?
So it depends where you are, because it's what different countries have different regulations in different parts of the world about second line therapies. So the most outside Europe, the most widely available drug currently is obeticholic acid. So that's one option. It's not that easy in Europe. There's at the moment with obeticholic acid, but there's two other second-line agents that are coming through in various countries. They're already through, and some are still going through the pipeline. In Australia, we don't have formal access yet, but we will shortly, to a drug called elafibranor and another drug called seladelpar, which are both very good medications and by and large very well tolerated medications. And in some countries, and until recently, we would use a group of cholesterol lowering medications, old-fashioned cholesterol lowering medications called the one that's most widely used is bezafibrate. In Australia, we don't have bezafibrate, but we use fenofibrate. So the fibrate class of drugs. In South America, they have a completely different fibrate. But so fibrate drugs are used. They're cheaper drugs, so they're used off-label, but widely used in PBC to treat the illness and to treat itch.
Great, thank you. We actually touched on this a wee bit earlier as well. The next question, is there a link between PBC and hormones? You were talking earlier about younger diagnosed women. If they then go into pregnancy, you can see things changing in their condition.
We don't. The truth is, we don't really know, because it's a rare disease and particularly uncommon in young women. And so we don't. It's really not been studied from a hormonal perspective around pregnancy. Probably unlikely. It's hormonally related, to be quite honest, but no one knows the cause, and there's lots of, we know people may have a genetic or genomic predisposition, and the feeling is their environmental or other factors that precipitate the illness. And they've looked at a variety of things like urinary tract infections as causal. There's a strong link to cigarette smoking. There's a strong link to certain cosmetics, perfumes, and certain supplements used in the environment, which they call xenobiotics. And so we don't really know the cause, and we don't definitively know if hormones play a major role, but we don't think they play a major role. But I'm going to put a caveat over that because we don't really know.
This is something that comes up quite a lot as well. Is PBC genetic?
It's partly genetic. We don't know the genetics. And we don't use the term genetics. People probably have a bunch of genomes that sitting in a certain part of the gene that are all related and can trigger PBC and or similar autoimmune diseases that sit in that region, like Sjogren's, like vitiligo, like pernicious anemia. So they're all sort of linked, and they're probably triggers and probably environmental triggers that we don't really understand. But yeah, that's probably the best way I can understand it. You do see it a bit more commonly in families and siblings. So not very commonly, not hugely commonly, but you definitely do see it a little bit more commonly.
Thank you. Just to say, I'm coming to the last two questions that I have on our sheet here. So the lovely people who have joined us in the room, I've got a very special opportunity for still having some time with Dr. Weltman. So if you have any questions, please pop them in the chat and I'll pick them up after I've done these next two. So our next one is, my hair has been falling out and the only thing showing on blood tests is that vitamin B12 is really high. Could this be high because of PBC or URSO? The only other symptoms they're having are insomnia. So
no, we don't even think high B12's that bad for you, but I don't know how high your level is, and I don't, it's not for me to really comment on yourself, but pernicious there's a disease called pernicious anemia, which you have a low B12, and that's more linked to PBC. It's associated with PBC, but not a high B12. No, and I don't think a high B12 is going to be harmful to your hair. So there's probably something else going on.
Great, thank you. So next question's around exercising. So I know exercise is good for us. I've started open water swimming, and was wondering if there were any issues to consider with having PBC. Now, I would like to point out that open water swimming in Scotland is a whole different ballgame to water swimming in Australia.
I would think, I couldn't even dream to think. But open water swimming is not going to be worse for you than someone without PBC.
Yeah,
If
and we
that's
know
your
the
thing,
importance of
go and do it.
Yeah, I've heard lots of good things about it. I know people who do it regularly. I've heard lots of really good things about it, and we know how important we say about movement as medicine, how good it is, not just for your general health, but for your mental health as well, if you're doing something like that. So,
sure is. Yeah.
So that's great. Actually, our Choose Me Tuesday that's coming up next week is, I believe, a movement as medicine special. So if anybody's particularly interested in that, join Cheryl for a chat about that. And I think perhaps Colette is joining that as well. Colette is very proactive in terms of movement as medicine as well. We were having a chat about that yesterday. So that's great. So I have I've got a couple of questions actually that have popped in late by email that weren't on the list, Dr. Weltman, but I'll try and cover those as well just now. I'll see someone's typing, which is fab. So we'll maybe have another question live in the room here. So we've got someone who was diagnosed in October 2024 with PBC. They've been told that the liver test results suggest a more inflammatory picture rather than the traditional cholestatic picture, elevated ALP. So our question is as follows: is inflammatory PBC more difficult to treat, and does it cause more damage to the liver and bile ducts compared to the cholastic picture?
The truth is we don't know. And if it's more inflammatory, sometimes your doctor will go through this process and think, is there autoimmune hepatitis overlap with the PBC? Because that's what we think of. And that both those diseases need to be treated if you have both. But I don't think you'll be I don't think you necessarily were less likely to respond to treatment. I think that's not necessarily going to be the case. I think you should have as good a chance as someone else.
Great. Question here in the room: started on second line OCA in October and my bowel habits have changed. I need to go to the toilet up to 4 times a day. Stool samples fine. Any other suggestions, as I like to go on long walks and feel that I can't now? So it's having a bit of an impact on quality of life.
Yeah, I'm not sure what to say. It's not a recognized side effect, but clearly that's what's happening to you. And medications can cause, lots of medications can cause constipation. You're gonna have to discuss this with your doctor and maybe switch to something else if it's that bad, or take something to help your constipation. I think that's the conversation you're going to need to have with the prescribing doctor.
Okay. Someone asking about, try to walk every day, but after has muscle pain. Heard about buildup of lactic acid, but I don't really understand how to deal with it. Is there anything I can do?
So I'm really not here as a sports physiologist and as a muscle doctor, because I'm not going to have any more expertise than anyone else. It's not from your PBC. So you may want to go and talk to your GP or talk to an exercise physiologist about that. And it may not be lactic acidosis, it may be something else. So I would suggest that you do pursue that further.
Great. If there's any other questions in the room, please let us know. I've got one more here on email as well. I suffer from small lesions on my skin, which take a very long time to heal, like months to heal. They're usually quite small, but appear randomly. They look as though they are healing over, but then open and go raw again. Could this be something that's related to my PBC?
Okay, that's a hard question. I don't think it's related to your PBC. I don't think they're PBC lesions, but you better go and make sure you've got a diagnosis as to what they are, I would think.
Mm-hmm. The only thing that I thought about that is potentially if someone's really itchy. I know when my itch was very extreme, I was having.
No, that's different if you've got an itch, but that's not mentioned, is it?
Yeah, no, and that was the thing that
you really have to. If it's not related to itch, you're really gonna have to have the.
Yeah, because that was what went through my mind when I read it, is that I've seen that, but not if they're just randomly appearing and with no reason. That's us come to the end of our questions. People in the room with us here, please take the opportunity, if you have anything else that you were thinking about asking, please let us know, and then we'll give it another 5 minutes or so. Dr. Weltman and I will let you get back to your patients, because I know you're right in the middle of clinic, and I will let you get back to your
patiently.
We have got through a ton of questions today, which is brilliant. Thank you so much for that. That's all our questions that we've been sent in the lead up to today, and the ones that came in yesterday, completely up to date. So that's brilliant. We've got someone typing in the room, so I'm just going to give them a few minutes. Oh, that's just a thank you, just to see if there was any other questions before I let Dr. Weltman back to his patients. I will cut you loose today, Dr. Weltman, and I will let you go back to your patients. Thank you so much for taking your time to speak with you all. Yeah, and we'll see you again soon. Take care.
Bye-bye, Mark.